where he talks about the fact there is a high level of morbidity or disability for the rest of a person's life, heart failure, ongoing chest pain, breathlessness, further heart attacks, premature deaths, the list goes on. And if you don't have the proper attention as those critical first moments. And he said it's a real mindset shift. We are not introducing any new resources for this pathway, we are just reshuffling them. And it's interesting to hear this sort of comment that how we can best utilize the resources, and that theme seems to have been coming through on a number of occasions. Would you please welcome Chris Gagliardi.
Bit of a lip there, at least.
We're in the right place.
Yeah, exactly. G'day, my name's Chris. I'm the National Patient Pathways Manager for St John. I'm not a good Anglican, and I'd like to start from a position of credibility. I was meant to meet our Chief Executive, Peter Bradley, for lunch. Both Andy and I from New Zealand actually forgot, and we were out shirt shopping. So, always best to start from a strong point with things like this. So thanks very much for listening. In this presentation I'm going to talk about a real mix of things, so safe and well patient pathways, which is St John New Zealand's approach to low acuity patient pathways. I'm going to talk about some of our priority high acuity pathways and destination policies, and what we're doing about the gap between high acuity and low acuity. So I guess the background, why are we here? Why am I talking about this? St John New Zealand, like many services, is burdened by ever-increasing workload. We've got an ageing population, a bulging population, but in New Zealand we're undergoing a real shift in the paramedicine profession. So we've always been an emergency service. We've gone to heart attacks and strokes and major trauma and everything else. But actually 81% of our work across New Zealand is what we call status 3 and status 4, which is minor and moderate. And while that's taken a long time to sort of dawn on us, this status 3 and status 4 work is not actually what some paramedics would historically have classified as rubbish, if there's effective ways of dealing with it. So that is why we're here. And so what is safe and well? So safe and well is our approach to low acuity, and it's a referral option for patients or their family who are safe to stay at home. So we've assessed them as safe to stay at home as per our clinical practice guidelines, but they have unmet health needs or require follow-up care. It's fair to say that ambulance patients are not all well-to-do. There's many vulnerable patients, marginalised patients. We deal with people at all ends of the socio-economic spectrum, but our workload is heavily burdened and heavily made up by patients that are at the lower socio-economic end of the spectrum. We've got many, like Australia, we've got many high-risk ethnicities like Māori and Pacific people, and New Zealand, by and large, has a very, very good health system. But what we're finding is ambulance personnel is people often don't know how to navigate the health system, they don't know how to access services. And so it's not an issue about what services exist, but there's a real issue and a real opportunity for us as a service to actually link our patients with the right care. And it would be fair to say, with our growing patient base in the elderly cohort, complex diseases, more than 20% of people aged over 65 on 4 or more medications, not all needs are now medical. You look at things like falls prevention. Gone are the days where referral to a GP is the only thing required. So while we're doing this, we've got a clear message from our funders around delivering care closer to home, around avoiding ED admissions or ED transports where appropriate, and we're really trying to provide the best care for people at risk of preventable diseases, with people with chronic diseases. And there's really, really good evidence that if you put things in place downstream, it really benefits people in the long run. Let's not treat established disease. Let's try and actually beat disease and stop it from occurring and link people with services early. And how are we selling this to our staff? Because the key of implementing any pathway through in an ambulance service is to get your staff on board. Is if we're selling to them, if you make a falls prevention referral today, it might be a fractured neck of femur that you're not going to at 3 a.m. in 2 weeks' time. So this links in with demand management and trying to keep people healthy in the long term. So how does it work? So we've recently, in the last couple of years, introduced the electronic patient report form system, and we're currently redeveloping that to better make referrals. But With our Safe and Well pilots, our low acuity pathway pilots, ambulance staff assess a patient in the community. They identify the patient's healthcare needs and they link them with appropriate services via our electronic patient report form. So I'll explain shortly, but we've got about 5 pilot sites where we've worked with our district health boards and primary health organisations to come up with a series of pathways, whether it's falls prevention, medications management, Māori health provider, respiratory conditions, where our staff can look at some referral parameters and they can make electronic referrals to health providers. And we've been really, really pleased with the results so far. The good thing about Safe and Well is, you know, we go to a patient that's not well connected with health services and we'll go, look, you'll be right, you're okay to stay at home, go and see your GP. Do they really follow up? Often not, often not. So the good thing about Safe and Well is a direct referral, we get the health service or health services to contact the patient. So there's a real feedback loop. So this is what we've put in place so far. So Safe and Well has been running for approximately 12 months. In Nelson, which is right at the top of the South Island. Great coffee, great craft beer, by the way, if you're ever looking for a place to visit. We've put in 11 pathways for patients who are safe to stay at home but have clear health needs. And we refer these patients to a district health board and primary health organisation, single point of entry. As you can see, we've got a range of referrals up there from cardiovascular disease / diabetes risk, falls prevention, respiratory conditions, smoking cessation, mental health. And so all of these referrals are made on our electronic patient report form. What this has done is actually changed the culture among our ambulance staff where they no longer see rubbish work as rubbish work because it's not rubbish because they can actually do something about it. Our culture is changing in that we're taking far more people to general practitioners and leaving far more people at home. We haven't encouraged our staff to leave more people at home. It's not about that. But if you are leaving them at home, connect them with the appropriate care. And that then revolves to actually change the culture. We've implemented a falls prevention pathway on the West Coast, which is one of the most deprived areas in New Zealand. It's the length, Karamea to Haast, west coast of the South Island is the distance from Wellington to Auckland for our Kiwis out there. We've implemented a range of other initiatives. A really notable one is our youth alcohol and drug referrals within Tauranga. So for patients that are transported and not transported, linking patients or their family with a youth alcohol and drug service. And we're actively assessing patients in Southland Otago, which is the bottom third of the South Island, for cardiovascular disease and diabetes risk and making referrals. We've got a number of other pathways under development. You can see the one down there, Kaitaia. So Kaitaia is a town in Northland, so right at the top of the North Island. And we've got some really good pathways under development there, as you can see. The key thing about Safe and Well is it's not a national approach, so as in we're going to implement all of these things in all areas of New Zealand, because of course community health needs are different. So what the needs are in Northland are not necessarily the same as Canterbury, and different health services exist. So for pathways to be successful, we absolutely need to have services available with capacity to receive referrals. The service must be able to action them, and there must actually be a community health need. There's no point referring patients to a service that doesn't exist or is over capacity, or where actually that referral isn't utilised because not many patients meet those criteria. So here's a case study, and this case is approximately 8 months old. So we've got, so it's 4:14 in the morning in an urban provincial area. We're dispatched for a fall, chief complaint fall. 5% of our ambulance workload is falls, very common. The patient has MS, he can't roll over or move in bed. But what the ambulance crew discovered is that there was a child sleeping in the same bed to save power. They were really financially deprived. They had a lack of home help. The house was messy, it was cold, and the child had chronic respiratory conditions or illnesses over the last several weeks. Now, previously we would have referred that person to his GP. He was safe to stay at home. He wasn't medically unwell, he wasn't hurt. But actually, by making a referral, and we encourage our staff to include as much additional social information in the referral as possible, health services were actually able to get a full picture of what was happening in this person's house. So, most of you here work on an ambulance. It's really interesting what you see at 4 o'clock in the morning. And whilst we are not the only health profession that does house calls, it would be fair to say we're now one of the only. health professions that does house calls. And we go to people's homes on an unplanned basis. They haven't had time to put the mats away that we told them to move last time. They haven't had time to clothe the kids, which are running around looking dirty, messy, etc. So we're really getting a good view into someone's social situation and then linking them with services. So a referral was made to the single point of entry, and the patient and his daughter were connected with multiple services: social work, home help, and of course a medical review for the child's respiratory illnesses. What was really important was the child then being made known to social services, so the health services weren't formally aware of the gravity of the situation. So who's involved? So safe and well, referrals, is it just an ambulance thing? And that's the question. And I guess St John, New Zealand, and many other St John sites around both Australia and the rest of the world are fortunate in that we don't just run an ambulance service and we have a medical alarm function, we have community programs or community health services that look after youth programs, Friends of the Emergency Department, care and caller. So we've got a very wide, broad organisation. With large and complex organisations comes challenges, but we've got an enormous workforce that is really keen to help. So what we are doing is we've got medical alarm reps that install medical alarms, but for the last 12 months they've been performing or undertaking ACC older persons home safety checklists. They've now done approximately 4,500 of those. And the next step is now to link patients who are at risk, so who have an abnormal older person's home safety checklist, with a District Health Board falls prevention service, just like our ambulance staff. So whether you work on an ambulance or whether you install medical alarms, you can refer patients to services. We've also got a great group of community programs volunteers, and they're going to be playing an important role in doing health screening at community events, public events, and then delivering or providing health services within their remit. So they're non-clinical, but they do have a lot of social expertise. And in an area called Gore, which is sort of right in the deep south of New Zealand, doesn't have good craft beer or good coffee, we're setting up a process where ambulance crews and the community can actually refer somebody for a winter wellness package, which is basically free blankets and free clothing. So should we just wait for the 111 call or the 000 call? We think no. We think that we can do better than that. We've recently, as you may have heard, we've recently been announced or been provided with additional funding over 5 years to double crew our ambulances. Sounds funny, but until now, on many of our ambulances around New Zealand, we've had one person, and that's been a huge challenge for us. But what we are keen to do is utilise that additional capacity that 2 people on the ambulance gives us in rural and remote areas. So not in busy metro areas like Auckland and Christchurch, but in rural areas we want to utilise our additional capacity to do more for the health sector. So we're currently working with the Superior Research Group to develop a risk model. So who is at risk of admission and who is at risk of readmission, looking at DHB data sets and Ministry of Health data sets. And once we've established that, we'll be working with District Health Board clinical steering groups to determine what interventions, what health screenings, what health checks could our ambulance personnel do in the home proactively. Now, because it's low acuity and it's planned, if chest pain comes in, a cardiac arrest, we can easily divert or not go. But we are going to be in rural and provincial areas in a steady way across New Zealand, with each local health service undertaking a model of proactive visits to patients. And we think we'll really pick up a lot of frequent callers, and if we can increase or improve community health, it'll be a lot of 111 calls we don't attend. So we're actually turning ambulance care on its head and trying to move from unplanned, unscheduled demand to planned and scheduled, where possible. So what about high acuity? So for the last 2 years, we've had a spinal cord injury destination policy, and what that has done is designated 2 spinal cord impairment centres in New Zealand, so one in Middlemore Hospital, which is in Auckland, one at Christchurch Hospital in the middle of the South Island. So if we have someone with paraplegia or quadriplegia from trauma, and they don't have other signs of major trauma, we will overfly or bypass other hospitals and transport directly to a spinal cord impairment centre. And the reason for that is to allow patients prompt access to spinal cord decompression surgery. We know this is time critical. We know, while we don't know the exact time where that surgery must be undertaken, we know it's definitely within the first 6 hours. And not having access to that is a major cause of morbidity for spinal cord patients. On the 27th of March this year, we implemented a major trauma destination policy. This is a big milestone for New Zealand. We have 20 legally distinct and separate health systems. We have had that since 2001, so getting agreement on a common triage tool for major trauma is a big step forward for our country. So what this essentially does is actually clarify what major trauma means. You know, it's not just a status code, it's a list of injury patterns or clinical impressions, so we know what a patient must have to have major trauma. We also have designated major trauma hospitals in each region, which really cuts out our transports to smaller hospitals that are not equipped to deal with trauma. And in cases where we've got lowly qualified or junior crews, we've implemented a concept called staging, whereby if it's not feasible or safe to get the patient directly to a major trauma hospital, we'll activate staging, a helicopter will be dispatched, we'll go into the nearest hospital for a life-saving treatment only, but we will take care of the onward transport to a major trauma hospital. 2,000 major trauma patients in New Zealand and each year, and 200 of them are always referred to another hospital, and that's what we're trying to minimise. Right care, right hospital first time. I was a bit disheartened with stroke. I was kind of excited about our stroke destination policy, and I heard at lunch that Ambulance Victoria had implemented a stroke ambulance with a CT scanner in the ambulance, which is extremely impressive. For New Zealand, we're not quite there yet, but again, what we now have agreement on is the clinical criteria to diagnose stroke, the stroke fibrinolysis timeframes, and we are just about to roll out this policy which designates stroke hospitals across New Zealand. So thanks to telehealth, we now have been able to commission a number of stroke hospitals capable of assessing patients with acute stroke, providing reperfusion therapy, and we'll be communicating that to our staff. We're also included in our acute stroke destination policies is ED bypass criteria, so we meet the patient, or we meet the receiving hospital team in ED, and if the diagnosis of stroke is clear, we go directly to the CT scanner on the ambulance stretcher, cutting down that time in ED. And this really sets the foundation in New Zealand for clot retrieval. So where an interventional radiologist literally, for ischemic stroke, goes into a large artery with a wire and literally sucks the clot out. By designating stroke hospitals, we're getting the patients to an appropriate facility where they can have their eligibility for clot retrieval assessed, and we're currently working with the National Stroke Network to develop a rapid transfer process from stroke hospitals to clot retrieval centres. So it's only about a third of stroke patients will be eligible for clot retrieval. And just like with STEMI, it's our view that if someone needs transfer in a time-critical manner, so time-critical as opposed to skill-critical, ambulance personnel are the people to undertake those transfers because we're primed to respond and we're ready to mobilise. So the New Zealand out-of-hospital STEMI pathway, so that's just been signed off by the National Cardiac Network a few months ago, and we're going to be implementing that in early mid-2018. So this is the current state of STEMI care in New Zealand. It's a bit of a patchwork quilt, and this is what we're leading with the National Cardiac Network. We get on scene at about 15 minutes, 13 to 15 minutes across the country, noting that a lot of our STEMI patients are rural and provincial. We get the patient to hospital at about 53 minutes, and that's just the nearest hospital capable of providing thrombolysis. They get their thrombolysis about 25 to 30 minutes after arriving in the emergency department. That's pretty good, but as you can see, myocardial salvage is really starting to drop. We're already an hour 20 in. 60 to 90 minutes later, the emergency department goes, oh, the patient hasn't reperfused, and they will try and urgently transfer them to a PCI-capable hospital for rescue PCI, and they'll get their rescue PCI quite often about 5 hours in. So if you don't live in a main centre, that is the sad reality of STEMI care in New Zealand. So what we're trying to do, and what we will do, is moving fibrinolysis to the field. So after we get on scene, we'll be liaising directly with a STEMI coordinator for each region, which is an on-call cardiologist. We'll be completing a contraindications checklist, and we'll be administering fibrinolysis if the patient can't be delivered to a PCI-capable hospital within 90 minutes. So upon talking to the STEMI coordinator or administering these clot-busting drugs, we'll be making a decision in conjunction with the cardiologist whether the patient's eligible to be transported directly to a PCI-capable hospital, directly from the scene, bypassing non-PCI-capable hospitals, with the hope that if someone needs rescue PCI because the thrombolysis or fibrinolysis doesn't work, they can get it in the time frame of benefit. Does that make sense? So the national STEMI pathway, as I've said, we're transmitting the ECG, but we're not hanging our hat on ECG transmission. New Zealand has a lot of cell phone black spots, so we're really training and encouraging our staff to interpret the ECG. And if they can't transmit it, move immediately on to step 2, complete the fibrinolysis PCI contraindications checklist, and then liaise with a STEMI coordinator. So even if transmission fails, describing the ECG to the STEMI coordinator is just as good. The role of the STEMI coordinator is to advise staff as to the destination hospital and what the treatment pathway will be. So if we can get a primary PCI delivered in an acceptable time frame, we'll always do that. But for the majority of New Zealand, and I'll explain it in a wee minute how New Zealand was settled, for the vast majority of patients, the reperfusion strategy will be fibrinolysis. And then all eligible patients will be transported directly from the scene to a PCI-capable hospital. A couple of interesting facts is in provincial areas in New Zealand, up to 50% of people who are administered fibrinolysis for STEMI fail to reperfuse. And as we've seen before, if you get your rescue PCI at 5 hours, it's really not ideal. I'm so passionate about it. I had a dream last night that I had an anterior STEMI. It was awful. It came close to the shirts incident. So quickly, the gap between high and low acuity. Look, we're of the view that there's a lot of conditions, a lot of pathologies that still require a specific level of hospital care, so are still time-sensitive, time-critical, or skill-critical. And all around New Zealand, because we haven't drawn a line in the sand and said this is where we should send patient group A and this is where we should send patient group B, provided it's feasible and safe, we're not always getting patients to the right place. So off the back of our major trauma policies and after we've implemented our STEMI pathway nationally, we will be providing guidance to our staff as to the appropriate destination hospital for all of these conditions and more. And we've currently got a survey out with our ambulance staff to see what their views are. And we're doing a series of literature reviews to determine really what is the full list of time-sensitive or time-critical conditions that don't fall into our other policies. So what's the problem with taking people to the wrong hospital? This is a review of patient transfer data within our central region in New Zealand. The hospitals have been anonymised. So as you can see, it goes hospital A through hospital I. On the left, in the middle column, you've got overall patient transfer numbers for that hospital. So the number of patients transferred from that hospital to another hospital. But on the left, you've got how many of those transfers were done within 3 hours of us transporting a patient to that hospital. Does that make sense? Yeah. So as you can see, hospital A, we transfer 1,690 patients out of hospital A per year, but blimmin' heck, 352 of those have to be urgently shifted in the first 3 hours. That's 1 in 5 patients that are transferred have to be shifted in the first 3 hours. So that is why we're very keen to implement additional destination policies. It's not just about patient care, it's about our downstream demand that it creates. Because we can't always resource those transfers within 3 hours. If we're out at an MVA and it's a smaller area, there might not be an ambulance to do that transfer. So right hospital first time logistically is really critical. And here's a breakdown of all of the things that were transferred out from hospital A within 3 hours. And that gives us a really good idea of what we need to be looking at for our destination policies. So some really clear categories there of stroke, myocardial ischemia, 14 fractured neck of femurs transferred out within 3 hours. So this stuff's really important, and we're going to be doing a lot of work on this. Just in closing, why is this all necessary, particularly in relation to high acuity? This is a picture of colonial New Zealand. There's about 52 territorial authorities there. We've got a little bit better than that, but we've still got 20 district health boards. In addition, because we're farmers and because our settlers established cities and towns in kind of clumps of 50,000, we're spread out. We're everywhere. It really is the land of the long white cloud. And roading networks back in the day weren't that great. Surgery was a lot more simple. And pretty much all hospitals in New Zealand could do and provide relatively similar things. But that's no longer the case due to increasing cost, increasing specialisation. And we now have to adapt to that and take people to the right place the first time. I was reading a overview, a Ministry of Health document on the Ministry of Health website from 1967. They were expanding the theatre block at Buller Hospital in Westport, which is right at the top of the west coast. Doesn't have surgery anymore. And that's it. Thank you.